for the day, and we'll get the day going. So thanks for all coming. Thanks for bearing with the weather and showing up. We appreciate that. So just going through the agenda here. We have a couple introduction stuff. We're going to have Dr. Blankenship talk to you guys. We'll give you a quick intro to ultrasound for those of you who don't know as much or haven't really used it that much. And then we're going to move you over to our clinical skills lab. We'll have 3 stations in the morning. We'll come back here for lunch, and the first part of our competition Ultrafest will be during lunch. And then we'll end the day back at the clinical skills center. So that's kind of the rough idea. We'll have signs over there as well to guide you throughout the rest of the day. You all got a name tag like this. This right here in the middle is the order of the stations. It's your schedule. Often the first going throughout the day. So keep your name tag. Those are the stations you're going to. There was some confusion with the numbers. Cardiac 2 and cardiac 1 are the same. The difference is we're trying to split you guys up to have more hands-on time. So make sure you go to the cardiac 2, not 1. It's the same material, just we want to make sure there's no overcrowded stations. And then the bottom is your team name and what room you'll be in for lunch for the Ultrafest teams. 160 is this room, the room right next door is 112, so they're both in the same building.
We're probably going to keep you all in here because our numbers have been removed for weather, so we'll let you know for sure as we.
We'll have these up, these are our kind of station maps throughout the hallways and the rooms when we go to the scanning sessions. The it's a little weird, but this is the hallway. It's not in the big room. We'll have 4 stations there. And this right here is the ultrasound room. It's a different room. We'll have signs for all this, and these will be up there, but just giving you an idea. This is the main room here. So we'll have one room, most of the stations, a hallway, and then a second smaller room, the ultrasound room. There'll be signs there to guide you. We'll have these up for every station shift change as well. But just give you an idea of going for your next station. Afterwards, we have a reception, happy hour at Zauber Brewing Company. It's one of my favorite places in Columbus. It's right up the street. So 5:30 to 8, happy hour, food, drinks. Please come join us there. Gives time for the roasted beer, and you guys can hang out. And just a quick thank you to Ohio State, the Medical Center, Emergency Department, and College of Medicine for helping us put this on. Dr. Bainers and Dr. Bolger are our faculty advisors. Countless hours in this with us. Executive and General and Secretary, Constant Staff, and Jenny Edwards, and a bunch of other M1s, M2s, 3s, and 4s helped us coordinate this entire event. We have residents, emergency medicine, IM residents as well, who are proctoring, moving them up on the stations. We have a longitudinal and ultrasound program at OSU, so we have a bunch of 4th year students who are trying to proctor you guys today too. We have a model pool where we train medical students to become ultrasound models, where you can have live people to scan on. They're all going through their time as well. We have an amazing guest speaker, Dr. Blankenship. We'll introduce him in a little bit. So he came down for this. We also have a special guest, Dr. Bruce Lewis and Bob Jones. I think Bob Jones is able to come with the weather. But definitely see him around often. They have a lot of execution skill. Finally, we have 7 amazing vendors who donated money and machines for this day. We have 39 machines donated from all 7 of these people. So their vendors, salespeople are here. They have stenographers who are here as well. They'll be up by the machines. So please thank them. They gave us a lot of help for this event. Also, apparently ultrasound's huge on the Twitter world. I did not know this, but definitely post pictures from today. Post the Ultra Quest for the competition, Ultrafest for the day. Without further ado, Dr. Bainers, our faculty advisors, can say a few words as well.
We give it up to our future Dr. Michael and Janet. I know it's snowmageddon out there. I can't believe that all the snow comes on this day, but really appreciate you guys braving the weather. I'm Dave Bader, I'm the Department of Emergency Medicine. I had a vision a long time ago that medical students could learn how to do ultrasound, and so we have been putting ultrasound in medical curriculum here at Ohio State. all the way to Med 1, 2, 3, and 4. Michael and most of the honor students are part of the fourth-year elective, which is kind of the capstone for our ultrasound program, where they have to get longitudinal lectures over a year's period of time. They have hands-on stations, they do journal clubs, and they all have to do a project. This is Michael's project, and he's done a fantastic job. When he was a first-year student, he went out to California, and Chris Fox, a friend of mine, started, he has the same kind of zeal toward ultrasound that I did. He worked with some medical students to put on something called Ultrafest, and what it did was he wanted to get vendors and students together so that they could learn about ultrasound, because not everybody had the same opportunities at the medical school. Michael came back and said we should do that here. He's been planning this. We'll try to put the Christian vendors. Again, we have Summerside, we have line break equipment on there, GE, Toshiba, Siemens, Sonari, and then we also have one of the world's best virtual way to demonstrate ultrasound pathology, Sonos Sim, which is going to be on a few stations, going to be highlighted in all requests. Craig Bolger is one of my close colleagues in emergency medicine. Together, we have put on events in every winter called the Ultrasound Olympics. We had to change that name because that was copyrighted, so we had to call it Ultrasound Challenge. And the purpose was to see if there's a competition with students who compete. We started all in the basement of this facility 5 years ago, and then grew to last year where we had multiple schools come and compete. We wrote that up in the Journal of Ultrasound. What we tried to do is combine that with this Ultrafest, so we came up with Ultrafest. So we're looking forward to the day, which is going to be a lot of fun. There's going to be a lot of education. There's a lot of knowledgeable people. There's equipment and technology. And then after we learn, at lunchtime, we're going to have a Jeopardy session, which is a round one of UltraQuest. Then we have a round two after Ultrafest is done, which is going to be a scanning challenge. And then finally, we're going to get down to a couple teams, and we're going to have a scan-off using the Sonos device. And so we're looking forward to the day. We have a couple of guests. Dr. Risa Lewis is a colleague. She's an ultrasound enthusiast. She's the ultrasound chair of the ASEP section in emergency medicine, American Health Emergency Physicians. And we'll try to path forward for all reasons now taking charge of that section. She's from Denver. She's come to join us. She's started an ultrasound industry group out in Colorado and wants to see how to put on an Ultrafest. Our goal eventually is that these kind of events could have regional competitions to go up to national meetings where there could be a competition at a national meeting, where there's an organization called the Society of Ultrasound and Medical Education. They have a World Congress each year. This past year was in Portland. And they had the Ultrasound World Cup, and we had a competition out there. But as this starts to grow, as more and more people do this, we're hoping that these kind of events could then lead to regional competitions, that could be a national competition with students just trying to promote ultrasound. So we're really trying to celebrate ultrasound today. We're really glad you're here. We have a great day ahead of you. There's going to be a lot. We put an agenda together. We're going to see we're going to be fluid and flexible as things may change. I want to just introduce a good friend of mine, Dr. Blankenship, who I've known for probably a decade now. He is an emergency physician. He's a former military. He's traveled across the world and taught so many people how to use ultrasound. One of my favorite stories about Rob is he was teaching. He wanted to prove that he could teach lung ultrasound. He taught it to a bunch of cooks on a military ship. He said, if you teach a cook, you need to follow a recipe. So he put lung ultrasound into a recipe so they could communicate that. Rob's a fantastic speaker. He's going to share with us some of the experience in ultrasound in the military, how it's being used, ultrasound in austere environments. So let's welcome Dr. Bob Blankenship here.
Well, good morning. There's nothing like coming in from the cold to a warm environment, putting a little food in your belly, and then letting you listen to somebody drone on for about 40 minutes. But this morning, I'd like to do really three things with you. The first thing is just sit back, relax, and for the first 20 minutes, for the first time in probably years, you don't have to take any notes. You can just kind of experience what I went through. And then for the next 20 minutes, I'm going to show you what we're able to do with ultrasound and teach you guys some of the lessons that I learned, albeit the hard way, about the true impact of ultrasound. And then the last 20 minutes, when you're really ready to go to sleep, I'm going to challenge you. And those who sit up front, sorry for your luck. Every environment. I trained in a very busy community emergency medicine residency here in Iraq. I've been in a level 1 trauma center. I've been in big regional medical centers. And I'm currently the chairman of medicine in one of my hospitals in Indianapolis. And I also staff 5 different EDs throughout town. I work with both peds and adults. So I've kind of practiced in every environment. But I got to be honest with you, the austere environment really opened my eyes to why ultrasound is so useful. And I'm hopeful that this morning, by sharing a few things with you guys, that you really start to see why Dave is so passionate about ultrasound, why I am so passionate about ultrasound. Because it's not just in Iraq or Afghanistan or on a submarine base or on Air Force One where ultrasound is really important. It's important in your patients' lives today. Now, I'd love to tell you that I led a charmed life. And in fact, if you go back in when I was at Fort Hood, Texas, I was vying to be the next program director. And I was pretty young for the position. And I'm like, all right, well, you know, I've got a pretty good chance at this. My boss called me and said, I'd really like to meet with you tomorrow. I'm like, this is the day, right? He's going to tell me you've done such a great job. You're such a good guy. Your hair is amazing. We're going to give you this program director spot. Unfortunately, that's not what he had to say. He said, Rob, I'm really sorry. You're kind of young. I think next time around you're going to be picked. But we do have a bonus for you, a paid year-long sabbatical in Iraq. So I'm like, sweet. My wife's going to be stoked. I told her when I left the house today, I'm going to get a new job. That was true. The job I got is not necessarily the one I was looking for. So when you work in the military, there's many different places you can go. You can go to the combat support hospital. They kind of play doctor. They have buildings where they take care of patients. It's not a whole lot different than your hospital. There's politics, there's lots of equipment, and there's lots of sick patients. But the Army also has a professional filler system. What that means is that you get assigned to a unit. So when bullets start flying, every unit has a physician. Well, I was assigned to 4th Infantry Division, 166 Armor. So that's tanks. So I had 650 tankers under my command, that I was responsible for. And so I'm like, I met the old man and he said, you know what, doc, we had an obstetrician before as our doctor. I'm pretty stoked to have an emergency physician, right? 650 guys, I've got an obstetrician, not a lot of help. So he said, we're excited to have you as an emergency physician. And I'm like, well, you should be. Well, that's nice. So we roll up to the jet. So we charter a jet to get to Iraq because that's how we roll. Thank you for your tax dollars. We go up to this American Airlines, and I'm like, yeah, this is looking pretty nice. They understand the value of an emergency physician. And then they go, doc, here's your seat up in first class. And I'm like, yeah, this is pretty good. They were like making cookies for us. These were lay down seats. It was nice. It was really, really nice. And then we arrive in Kuwait, and they take us to our quarters. And I'm thinking, well, I was in first class. Pretty excited to see what kind of room they put me up for the night. It's pretty nice. You all laugh. This tent is nice. It was about 120 degrees because it was 3 a.m. It was the cool of the day. And this tent has a air conditioner, so it will drop the temperature at least 20 to 30 degrees. Now you may say on a hot day 135, it's 105 in the tent. That's hot. Nay, nay. Go outside. That's hot. You come back in. It feels wonderful. Now, it does change. You get into the tent, you're freezing, you get under the blankets by morning, you're sweating, you walk outside for 5 minutes, you come back in, you feel good, you go back to sleep. This is my medical crew. This is it, 650 guys. Let's see here. I am the ugly dude there on your left. The next guy over is my PA. He'd been out of school for a really long time. I think he graduated 30 days before we went downrange. The next guy was a medical platoon leader. He's kind of like the hospital administrator. That's why he has that funny look, because he has no clue what he's doing. And then the next guy over is an orthopedic PA. Great guy, been to Kosovo, really a good guy. And so we get to Kuwait. It literally is about 130, 135. It's toasty. And we start doing sick calls, see a lot of nosebleeds, really don't do anything. About 6 days later, we line up. Now, if you've ever done medicine in an austere environment, I don't know what you are envisioning, but this is it. These vehicles are 113s and 1068s. That is my mobile care location, if you will. So when we're on the road, this is where we take care of people. I don't know if you've ever been inside a tin can at about 130 degrees. It's hot. We sat inside these for about 12 hours one day because, we weren't ready to go. It was nice. And then we finally pushed into Iraq. I don't know what the road laws are, but evidently when there's 100 camels who have to cross the street, that takes priority over 250 tanks. So we stopped. I don't know what you guys see in downtown Columbus, but this was new to me. We kind of watched these camels and like, this is pretty cool, I think I could dig this. I mean, it's not the hospital, but I think I can tolerate this. The other thing that was interesting as we went into Iraq is that there are all these kids lining the street. And they're waiting, and they kept going like this, like, I'm hungry. And you're like, oh my gosh, these kids are hungry. So we're throwing food out. Within a couple of days, like, no, keep your food. It tastes horrible. We ain't saying it's all good. But, we saw a lot of kids, when they would stop, they would come up and try to tell you, they're sick. They really just want to hang out with us, which was kind of cool. And then we got to Crib. And again, I started having visions of grandeur, right? I'm looking at this joint, and I'm saying, this isn't too bad. This is just the entryway. Right? This is nothing. They had about 6 palaces on which a great compound, and I'm thinking, I just need one for my aid station. It's looking pretty good. But unfortunately, that's not what I was assigned. This is just where the division was. We actually got assigned to Samara. Now, this is the guest quarters, former guest quarters for Saddam Hussein. And this was one of his garages that had a tile roof that just kind of kept some of the cars and stuff like that. So pretty nice, but not the town I took over. We took over the town of Samara, and that was my area of responsibility. Some of the religious holidays, we had about 1.5 million people in the town. You talk about a mass gathering event. There were some interesting days when you have 1.5 million people, you have 2 PAs, an emergency physician, and about 20 medics. So this is Samara. If things ever settle down, it's actually quite a beautiful city. This is the Al-Hadi Mosque. It's considered, I think it's one of the top 5 religious sites in the Muslim faith. Absolutely beautiful from the outside. You're not allowed inside the mosque with weapons, so I never saw it because you need to be armed. Unfortunately, after our unit left Samara, about 6 months after that, there was actually an explosion there and demolished half of the Golden Dome. Some other sites that we had that we were responsible for maintaining in Samara. This is a spiral minaret. This has been around for a couple thousand years. Absolutely an amazing structure. Luckily, we were able to talk to some of the religious leaders to get special permission to go up on the minaret and take a look around. And so, I'm starting to think this isn't too bad. I've been around for weeks, the honeymoon's on, everything's good. We also were in charge in Samara for making sure that the ancient ruins in the city did not get violated because of the violence in Iraq. So this is some of the ancient ruins that we were responsible for. We quickly found out that the closer we were to this, the more mortars that went in it. So we actually positioned ourselves about 2 to 3 clicks away from it, just so that as people tried to mortar us, they wouldn't damage the ruins. So as you can see, kind of a beautiful city. It's like, well, if I'm going to be a battalion surgeon, at least I've got a nice city. It was really nice for about the first 3 to 4 weeks. After that, not so nice. This is some of the things that we encountered. As if you guys are not aware, evidently as a physician, you're also called to be a veterinarian in the military. One of the general orders was, under no circumstances are you to adopt pets. That lasted about 3 weeks until my commander said, Doc, the boys want a dog. So I strongly encourage against that. Doc, I'm telling you, we're getting a dog. Yes, sir. So this is one of our puppies. I know that you have heard that there are no chemical casualties in Iraq. That's not true. I treated the first chemical casualty in Iraq, and that's him right there. He got into the fly paste, which has organophosphates in it. Luckily, in the military, what do we all carry on us? 2-PAM and atropine. What's the problem? Those are adult doses. I don't do much veterinary medicine. Well, he's pretty small. So we shot the auto-injectors into a urinalysis cup, and and then drew up the appropriate dose, and then gave this dog a gazillion shots over the next 2 to 3 days. Dog survives. Unfortunately, you've all seen a skin popper, right? What happens? Abscesses. So I drained about 30 abscesses on this dog over the course of the next week. He survives until the next order attack. That was the end of our puppy. Sorry, girls, sorry. Sorry. The guys are like, next slide. And then, as if it's at the end of it, I'm whooped. Well, this thing was on a piece of paper. And when I went to my mom, I found the paper, but he was gone. And I said, hey, did you guys get rid of the scorpion? No. Hey, did you throw away that scorpion? No. Don't worry, Doc, it's dead. This thing's so nice. He actually got in my blanket. He was warming it up for me. So this, you can't really tell. This is actually like a girly spider. It's like maybe as long as my palm. I actually saw scorpions, the body was this long, not including the tail. So I decided he was not sleeping in my bed for the night, and he succumbed to a close head injury. We also had some electrical injuries. I know from this slide you can't really fathom why. But the Iraqis, we bring in local Iraqis to kind of wire up our electricity, and they give us best quality. So you can see here we've had a few fires. And the other thing is the water heaters, the electricity, they didn't have like a special coil that went into the water to heat it. So about every 3 months, they would lose that protection. And as you know, when you turn on a shower, your hand is dry. But when you turn it off, your hand is wet. Electricity conducts much better if it's wet. So about every 3 months, you hear a scream, and then it's kind of a big boom where somebody got blown out of the shower, and that's how we knew it was time to change the water. So, we had typical, things like that. This is my aid station. Try not to be jealous. I know this is the Ohio State University. You probably don't have kids like this. But this is where we took care of our guys, and this is also where 30 of them slept.
So if you can't tell, it's kind of hard to see, but there's some boots in here because this was an elementary school and, you know, kids wear cover this all the time. So this is basically, this was an elementary school that actually was kind of a military headquarters, if you will. We figured if they labeled it as a school, we wouldn't notice the tanks outside. So after we took care of that, we took this area over because it had concrete, which is really nice. People are lobbing mortars at you. And we kind of cleaned the joint up. It didn't clean up too bad. And again, try not to be impressed. We have these litters. They're kind of like your automated beds that cost $3,000. These only cost like $800 probably. We have our medical supply area. We have IV fluids. Check it out. We got a sharps container. That's pretty nice. And this picture will not come out of this lecture because this are called oximetry. That's the most sophisticated piece of equipment I have. That's it. This is where we took care of over 100, what you guys can call them level 1 traumas in smart Iraq. So kind of interesting digs. Now I talked about some of the more mundane stuff that we saw, but you know, obviously we're not Boy Scouts, right? And these guys are driving around tanks with big guns on them. So we saw a lot of different things. So this is one of our border platoon officers. He's got a little concrete in his face here, a little concrete up here, basically an IED blast. Not too close proximity, I think he's about 50 feet away. He's just got a couple stones, no big deal. These guys, it looks pretty nasty. I don't know how much you guys know about RPGs, but this is the telltale mark that your vehicle's been struck with an IED. This is what a tail fin looks like. This is soft skin Humvee. Fortunately, the guys were really close to the Humvee when they launched this, and the RPG almost went through the entire vehicle before it exploded. So even though this was a soft skin, and you can see some damage to the vehicle, most of the people actually fared pretty well in this issue. For those of you guys who've never seen a tank, you might notice that something is missing, right? The big turret that lobs the big rounds downrange. So even though we were not fighting an enemy that had tons of things, they did like to stack anti-tank mines. So this thing ran over 10 stacked anti-tank mines and it blew the turret 1 football field away. We lost 1 of the soldiers and 3 others critically injured. This guy here had been in country about 3 weeks or so. An RPG went off while he was up on the tank, and basically some shrapnel wounds to his anterior and lateral shoulder. He actually did quite well. He was out of the country for about 6 months healing this up. Obviously, you see a few gunshot wounds when there's a lot of people around with guns. This is one of the enemy combatants who suffered a gunshot wound to the abdomen. So, you know, typical stuff that you would expect in the military environment. This guy was sleeping when an RPG came through into his quarters. He had, I don't know, I'm guessing about 50 to 100 holes, lots of really small, hard to see. So this is kind of the typical fare for us, and this is our aid station. And as you can imagine, that presents some big challenges, right? I mean, think about, I don't know where you guys are, I know there's some first years here, second years, and there is life after biochemistry. For you third and fourth years, you may have had an semester rotation or trauma service. This is probably, I'm just going to go out on that, I haven't seen the trauma center, but I'm pretty sure this is not how you guys roll. Now, we have automated blood pressure cuffs, right? I look at smart and I say, give me a blood pressure every 5 minutes. And say, yes, sir, in 5 minutes I have one. But that's how we took care of patients. And so I say those things to say, let's go through what I saw and let's think about it a little differently. Because when you think about foreign bodies and other things, how do we evaluate that in the United States, right? We have all this fancy equipment. We've got CT, we have X-ray, we have MRI. It's almost limitless what we have. This is us taking care of a few enemy combatants, you can tell, because they don't have boots on. Okay? U.S. soldiers wear boots so people don't look like this. And you have very limited equipment to take care of. These guys weren't too bad. They got rolled up. They were minding their own business when an RPG shot at us from the same location they were at. These guys weren't too bad, but you know, there's a lot of guys who came in. And the first lesson I'd like to teach you this morning is, when you carry a hammer, everything looks like a nail. You ever met an orthopedic surgeon, right? That patient can be coded, and what do they say? You got a broken bone, I need to take him to the OR. You know, if we get a pulse back, we'll let you do that, right? These guys are kind of doctors, they don't wear a stethoscope for a reason, they don't want to be confused with an actual physician. So, sorry, because they're big, and I don't want to. But in all seriousness, when you carry a hammer, everything looks like a nail. And I'm here to tell you today that you're going to play with the hammer that I love the best, ultrasound. Because think back to those pictures that I showed you on the type of casualties I saw, and let's think about them a little bit more clearly. I don't know how many foreign bodies you've seen in your practice, but most of your patients come in and they're like, I stepped on a thorn and I have a hole in my foot right here. You probably know where the foreign body's at. When you drop a mortar, like a 120 mortar or even a 55 millimeter round, you can have a hole here, and that piece of shrapnel can be in their hand, or it can be in their shoulder, or I've even seen guys with holes in their groin, and I line the shrapnel on the apex of their lung, because there's primary blast injuries, secondary blast injuries, tertiary blast injuries. You don't know where these things are. So here's this guy here, right? I saw probably 300 foreign bodies in a period of a year. Most of them are blasted. You can push on them, and what are you supposed to say? Well, it hurts when I push there. Well, sure it does. You got shot. You had an RPG go off. But with ultrasound, you can look, and you can tell them exactly where the foreign body is. And you can see, this is a hand form body. You can see if it's in the actual joint or if it's not in the joint. You can see if it's in the tendon or not. Because the deal is, when I evacuate you from my area of responsibility, I am not going to see you for another 6 months, and there's nobody who's going to come do your job. And you don't want Dr. Blankenship securing the compound at night, right? You want the guys who carry the weapons for a full-time job. So we're able to use ultrasound to quickly identify foreign bodies. How about this kid? In the United States of America today, this kid comes in, we treat his pain pretty aggressively, right? We do conscious sedation before we wash this wound out. Now, this is a young soldier, and I can tell how, because he's not fat. Tankers are fat. They ride everywhere in the tanks, right? That's why I walk when you can ride, right? House of God. Why stand when you can sit? Why sit when you can lay down? Why stay awake when you can sleep, right? Well, evidently they read it too, because tankers, if they could drive their tank down the hall to use the bathroom, they would. They're fat. And the problem is, when you're getting shot at and you sedate a 280-pound man, and they start walking the borders in, guess who's got to drag his fat hind end away? Me. And I'm already having enough with all my gear on. I don't want to drag this fat hind end. I've got my own fat hind end. I need to get out of the area. So what we would do is we take ultrasound and we do an interscaling nerve block, and this guy would have absolutely no pain, and we could completely evaluate this one. We could completely wash this out, and he'd feel great. We do nerve blocks for feet, you name it. If I could block it, I did. Because I could completely control their pain. I didn't have to deal with a sedated soldier on the battlefield where we were literally still taking fire. And more importantly, I don't have to worry about this guy stopping breathing because I give him too much medicine. And last but not least, do you think this guy's going to have pain for 1 day or 30 days? He's probably going to have pain for a long time. And the more nerve blocks we use, the less we have of narcotic addiction and abuse. How about this guy? He takes a round to his belly. I don't know where you're at in your training, but the first rule of emergency medicine is bad. Not bad. Bullet to the abdomen? Bad. Okay. But where is it bad? Was he laying down when he got shot? Was he standing up when he got shot? Did his IVC, did his aorta, did his kidney, did his bladder? With ultrasound in 2 to 3 minutes, I can tell you if he has free fluid in his belly, if he has a pericardial effusion, if he has fluid around his belly. It literally takes me 2 minutes. How do you do it? You probably send them down to CT, right? Because that's how the radiologist puts their kids through college. How about this guy? 50 holes in his chest. You ever been shot? It sucks. And I say those things, you're like, yeah, okay, tell me something I don't know. Here's what you don't know. What are we supposed to look for in a pneumothorax? Tachycardia. I got news for you. You get shot, your pulse goes up. You might have to change your britches too. It's not a good time. Does your chest hurt? Yeah, I think it does. I got 50 holes in my chest, right? You having a hard time breathing? Yes, it hurts. And before we acquired, which is a military term for stole, those pulse oximeters from the combat support hospital, we had no pulse ox, so you can't rely on that. With ultrasound, I can tell you if this guy had a pneumothorax or not. Now, this is a pneumothorax, but this guy actually did not have a pneumothorax. we were able to not place chest tubes in this patient, which is a big deal because you guys call medical supply and are upset because you don't have a growth culture in the room. I have to have somebody fly 300 sometimes miles to bring my gear in Iraq if I run out. So we really need to know who's sick and who's not sick. How about this guy? You're probably saying, wow, I knew these military guys were hard, but this guy has an open head injury, and they've got him with handcuffs on. Not true. He was minding his own business when two dudes rolled up and shot an RPG off. And they were so excited they didn't wait for the chamber to cool. They shot another one off. But unfortunately, if you don't let them cool, the round cooks off in the device. And so this is actually the two dudes' blood knock is. But with ultrasound, I don't have a head CT, but I can look for increased intracranial pressure. How about this guy? He's one of my best friends. He got a kidney stone one day. How do you tell that in the field? Ultrasound. How do you keep from hitting it when it's 100 and some degrees? Evidently, you put an IV in when you're carrying litters all day. So this guy put his own IV in and carried about 80 litters one day. He said, Doc, I must have done well. I didn't get another kidney stone. I said, well, that's fine. If you're the guy, I will still catch you here because I can tell you if you're instructed or not. This guy was on the checkpoint and he got ran over by a car or got rolled over the car. So here's his right frontal bone. Is he on a hematoma? Here's his left. Here's a little tip. One side always looks like the other. Here's another tip in ultrasound. If you're born with it, it's round. So when you see right angles, you've got broken bones. This guy had a frontal skull fracture, GCS 15. No, he said he had no headache, he had no nausea, no vomiting. But I can make a decision at 3 o'clock in the morning that this guy needs a burn, he needs it now because he has a skull fracture, and my aid station is not the best place for him. How about rib fractures? It's great. Not only can we tell if you have a pneumothorax, I can tell you if you broke your rib. And I can tell you when your callus has begun to form, so it's ready to put your body armor back on and go back to work. We don't have enough time today to go over the hundreds of cases that I use with ultrasound. But I hope you quickly see that why I say when you carry a hammer, everything looks like a nail. Because this ultrasound machine is all I've got. And so when I went over to Iraq, I'm like, all right, yeah, we'll do a fast exam. I mean, I can do that, whatever. But I didn't really believe. I wasn't drinking the Kool-Aid. But when it's all you have and it's literally someone will die in front of you if you don't make the right decision, and to be blunt, someone will die if you make the wrong decision evacuating the patient. We lost an entire medevac crew flying a guy out one day. So you really need to know when you're going to bring that bird down because they can get shot out of the air. They can have an air accident coming in. They can get blown up on the LT. One of the generals came to visit, like, sir, I wouldn't need your helicopter there. Oh, it's totally fine. Halfway through the general's briefing, boom, gets up. I don't know how much a helicopter costs. They're not cheap. Thank you very much for your tax dollars. They blew it up. So you really need to know when your patients are sick. So I'd like to go into a few rules, and then we'll wrap up with a challenge. The first thing I learned about ultrasound in Iraq is that, you know what, ultrasound is not a spectator sport. You know, I played the lip service when I was an emergency physician before I went, but I truly fell in love. And I don't know if you guys remember December 2013 is when the caught Saddam Hussein. We were doing a big mission, and it was my job to stand up the mobile operating pre-screening area for the mission for the capture of Saddam Hussein. So they're like, all right, Doc, here's your thing. And I'm going around, and there's a surgical team in town for this mission. And I see an ultrasound machine. I'm like, hey, where'd you get that? Oh, you can't touch that. That's the surgeon. You can't touch that. He doesn't let anybody touch it. You know, surgeon. So I go find the surgeon. I go, hey, I saw you have an ultrasound machine. I really like to use it. He goes, dude, you show me how to turn that thing on. It's yours. I've been dragging this thing around for 6 months. I have no idea how to use it. After the mission, I did 15 ultrasounds. He's like, looks like you can use it. How about you sign my hand and see how good it is? But you all laughed, but how many people in the hospital use ultrasound today? Do all your attendings know how to use it? Why not? You wonder why? Because we get lazy. We like to order studies, right? And the radiologists, what are they going to say? Oh, he's gone. I don't want to give you more money. Right? No. I got a kid in college, save it right now, it just costs me a fortune. Order whatever the hell you want. Right? The other thing is that we have these conceptions about what would be useful. When I went to Iraq, I thought, you know, we're going to do a ton of fast examinations. No. What we found when we taught this to the special forces operators is that trauma only comprises about 31% of what we do. Because when you're 10,000 feet on the mountain, you know how you tell a fracture? Ultrasound. Increased intracranial pressure, right? High altitude cerebral edema, ultrasound. Okay. So we found out that there are so many other uses for ultrasound, just like we were seeing in my town. The other thing is politics can hurt or help. Now, I know as medical students, you go, oh, I can't fight the political battles. Yes, you can. You know, Dave kind of stole my thunder, but when I came home from Iraq, I was like, this really needs to be taught on the battlefield. So I took a special forces medic with me and we went to meet the head of radiology and I said, hey, I think we should be training these PAs and these special forces medics how to do lung ultrasound on the battlefield. Long and short is I got thrown out of his office. And his parting words were, who are you going to train next? The cooks. So I'm walking back to my office and I'm halfway there and Monty says, that's a great idea. I'm like, what are you talking about? He goes, let's do a study. Let's train the cooks. Because I personally think it's not that hard. I bet we can train the cook how to do ultrasound. So we did a study and we got physician assistants, special operations medics, conventional medics, and veterinary techs, and food preparation specialists. They're not cooks, but food preparation specialists, and I use that term food loosely. And you know who did the best? Who did the best? The cooks. Why? Because the doctors are too smart to listen. The PAs, yeah, I got that. But you know what the cooks do? They follow a recipe. They'll do exactly what you tell them. You know, ultrasound is not rocket science. That's why I can get up here and say I can do ultrasound. It's not hard. It's not easy. But if you're willing to put the time in, it's not that bad. And that leads me to my next point, which is, you guys say, well, I know Dave is telling me I should do ultrasound, but I'm just a medical student. I've got news for you. Training is more important than titles. I don't care if you're the cook. I care that you can do the scan. I don't care that you're a PA. I care that you can do the scan. Who did I teach second after myself and I ran? My PAs, because if I got shot, I wanted someone to know what to do. And in your hospitals today, who's the most expensive? You are. So why not train someone who doesn't cost as much money how to do this life-saving skill? The other thing is, in hospitals, we change our practice based off what time of the day it is, right? Who can get a PIC line at 2 o'clock in the morning? Oh, no. The PIC team leaves at 4. Oh, that's right. Nobody needs a PIC team at 2 a.m. Yes, they do. Why do we have calendars? So we can mark off 10 years in practice. Because we'll do the studies, and 10 years later, we'll actually start practicing them. That's why. Why do you have to wait 10 years to implement something that is known to be true? You know, Steve Jobs said that people who are crazy enough to think they can change the world are the ones who do. And here's where the rubber meets the road. How many of you here today have seen somebody with shortness of breath? Anybody? It's pretty common, right? What do? How many of you here would order a chest x-ray on a patient with shortness of breath if you saw them? Raise your hand. Come on, let's act like it's American Idol. Everybody votes, right? It's not an election, it's an idol. So almost everybody in the room would order a chest x-ray. How many of you would order an ultrasound for your patient with shortness of breath? Okay. Why? Why do you not love your patients enough? Now you laugh, but what does the data show? The data is clear. If you ask a radiologist to interpret the chest x-ray for signs of congestive heart failure, they are right 69% of the time. Well, Rob, this is the Ohio State University. We have this test called BNP. We're not operating in BFE, right? We're operating in the hospital, dude. Okay, get your BNP. Specificity, 74%. Sensitivity, 90. Ultrasound? Yeah, it needs it. So why do you not order an ultrasound for your patient? It's better. It's cheaper. Time magazine says radiation's evil, right? It's a new medical journal. Why are you radiating your patient? You say, well, I'm worried about pneumonia. There could be other things. Ultrasound's better for pneumonia too. You say, well, that's for peds. Yeah, here's the adult side. Ultrasound's better for diagnosing pneumonia than your stinking x-ray machine. You say, well, Rob, I gotta know, because they might decompensate, they might need intubated. What do you do when you intubate your patient? How many of you guys here use capnography after you intubate a patient to make sure you're in the right hole? Why do you do that? You got to bag your freaking patient. What do you do when you bag the stomach? You increase the risk that they vomit, which increases the risk that they die, which increases the risk that you get sued. Why don't you watch it real time and see who's innovative? Because you can see the trachea and you can see the esophagus real time. And when you innovate the goose, you get a double bubble. What's a double bubble mean? Anybody? Double bubble, double trouble. Because if you innovate the esophagus, it's kind of hard to ventilate the lungs. You can see real time. This has been shown to be equivalent to capnography. And if you already own the machine, why do you like capnography? Well, they can code, right? If I innovate them in the goose, I guarantee it'll die. What do you do in a code? How many of you guys pull an ultrasound for every single code? Do not love your patients. Because think about PEA. Ultrasound tells me, is this true PEA or is this pseudo PEA? The guy I saw the other day with half a fence post hanging out of his neck. They said he's dead, he has no vitals. I took a look at his heart with ultrasound. That heart's going a mile a minute. I promise there's nothing in it. We filled up the chambers, took him to the OR, left the hospital. They're going to call the code, right? No signs of life. I respectfully submit, nothing says that you're alive like a beating heart. Also respectfully submit, nothing says dead like a non-beating heart. How many of you guys ever been to a pediatric code? They last for days because nobody wants to say they're dead. You show mom and dad a non-beating heart, and 30 minutes later show them a non-beating heart, they need to stop. And they're right. And the other thing is, what else causes PEA? Pneumothorax. Oh yeah, we can see that with ultrasound. Tamponade. You're never going to hear that. You can see with ultrasound. Hypovolemia. Yeah, we can do that. PE. We can look for indirect signs. Now you can see a couple of PEs on ultrasound. Folks, I say these things, and I'm happy to stop and say we have a lot of important things to do today. But I've changed Steve Jobs' quote. The people who are crazy enough to think that they can change medicines are the ones who do. You see, the question is, are you crazy enough? But I'd also say that you don't have to be crazy. I hope you don't have to go to a foreign country and literally get shot after 365 days to change your practice. The fact of the matter is that you've been lied to, and they're lying to you on a daily basis. They tell you that your patients need a chest x-ray, and quite frankly, you're wrong. Your patient needs an ultrasound. Are we not called to do what's better for our patients? Are we not called to lower costs? Are we not called to save lives? That's what this does. I realize a radiologist doesn't make as much money, but I don't practice emergency medicine to fill their bank account. I practice emergency medicine to make a difference in my patients' lives. And the fact of the matter is, regardless of your title, regardless of what year you are as a medical student, you have an obligation to your patients to do what's best for their health. And I respectfully submit many times that's ultrasound. Thank you so much for your time. I'll take any questions you guys have.
Any questions for Dr. Blankenship?
All right, thank you very much.
Well, real quick, so it seems like some else here in Barnett, so I was fascinating too, because a lot of penetrating trauma, so it's not like blood trauma.
Well, you know, we do see blood trauma, and obviously you can have a positive effects with blood. But you know, what we found was serial fast is obviously very important. And if they have fluid, it helps me decide how fast to call the bird. But the other thing is there's a lot of sequelae. We saw a lot of blood chest trauma. So for us, it's like, okay, your fast is negative, but do you have a pneumothorax? Okay, you don't have a pneumothorax, but do you have a pleural effusion? Okay, you don't have a traumatic pleural effusion, but do you have a rib fracture? Oh crap, you've got a rib fracture. Now, I don't have to evacuate you for that. In fact, I can actually block that and completely resolve your pain. But I can also follow you serially with ultrasound and tell you when your callus is forming and it's ready to get on. The studies are not as good for reducing fractures, but that's what we use for that as well.
Well, you found an obscure environment, all of these kind of uses that may be a little bit esoteric in tertiary care center are actually very practical. There's foreign bodies.
Foreign bodies, fractures are incredible. You know, because, I mean, think about it. You know, when you see a fracture in your emergency department today or wherever your practice environment is, you know, oftentimes we're going to just put a cast on that, or if you're going to reduce it, you're going to do conscious sedation. But with nerve blocks, hematoma blocks. I blocked hands with 30-gauge needles. Something you never do in actual practice without ultrasound because you're supposed to pull back and see the blood. But with ultrasound, you can take a 30-gauge needle right down to the fracture site, numb up the entire finger or whatever you're using, do the reduction, look at the reduction, and then put them in the splint. And the difference is now I've got someone who's comfortable and properly managed. I can take longer time evacuating them, so I don't have to put as many assets at risk in the middle of the night. We're securing a landing zone is a higher risk endeavor. It puts our medical crews at risk. In Africa, where we practice, same thing. It's really nice out when you're on mud hut to kind of take a look at these kids and say, you know, hey, I think we have a problem, or I think we don't. But we definitely found that MSK is a much bigger issue. You know, somebody comes in, they sprain their ankle, it doesn't look too bad, but if you look at their ankle and they have a big infusion, again, a nice way to treat patients is going, you do an inarticular block, you give that patient really long pain control, and allows you to, in some cases, we reduce, you know, ankle fracture dislocations with absolutely no chemical sedation whatsoever, and the patient had a pain-free experience, which is good if it's your flow.
A couple of questions. Sure. So I was just wondering if you had any practical advice for, I feel like when I go to hospitals on rotations and I see a situation where, hey, we could maybe do a point of care ultrasound on this, but the residents or attendings aren't familiar with that application of ultrasound. Do you have any advice on how to go about
Changing their perception?
Yeah.
So you're saying that so you go to a place and maybe you know how to do ultrasound, but your residents and attendants don't know how to do it or not working.
Right. So if there's like a pediatric pneumonia situation.
Yeah, so I don't see that changing tomorrow. That's some pretty new literature I talked about. But I think it's coming, right? Because everybody's trying to lower radiation fatigue, et cetera. So there's a couple techniques, and I'll just start by saying I'm not the most politically correct guy in the world. There's many ways you can do it, but the reason I think a lot of people don't do it is because nobody wants to look like a dog, right? Nobody likes to fiddle power around with a machine that they don't understand. So a lot of the time, that's the hesitancy. And once you overcome that educational gap, then you're much more likely to get there with the individual you're with. And as a medical student, it is hard to impact that, right? Because I find the best way to make impact true lasting change is by building relationships. Because when you first come into a hospital and you meet a radiology group, they're not really interested in what you have to say. And you have to win the battle on patient safety. Finding those unique cases, that's how you convert believers. And so that's one of the reasons why I'm a big fan of online education. Because I'm here today and I'm teaching however many are here, what, 80, 120, whatever. I can reach you today, but on the web, I'll probably reach 500 today. And I can show them the cases. And so I think that's the other thing, is you have to have the great cases. You show them the state, you show them how it changed somebody's care for the better. That's how you win them over. It's not going to happen overnight, though. As a medical student, you are disadvantaged, right? Because you want honors or high pass. And you're probably not going to get it by telling them they're a dog. But sometimes that's what's needed. I would recommend it towards the end of your rotation. Anything else? All right. Hey, thanks again, guys. I appreciate your time.
I think that's what the issue is. There's an educational gap. Technology is outpaced education. You're going to see some equipment today that is so fantastic, some of the things that you can do with it. But the whole thing with ultrasound is concept, since the beginning I've been reading the literature, it talks about operator dependency. If you get a CT scan, the spleen is always in the same place, whether you're 400 pounds or 150 pounds. With ultrasound, it depends on you on how to get some of these images. So that's what we're going to try to do today, is get you guys up to speed with some ultrasound. I want to introduce Dave Hartman, who's one of our fourth year honors students. He's going to just give a brief presentation on some terminology. What we've done here at Ohio State is we've written a couple of papers, one of them called the IM technique and how to approach a focus ultrasound. What we're talking about today is a focus ultrasound rather than comprehensive. We're going to talk about some of the three colors that we will see today, how to interpret the images. So let's welcome Dave Hart.
Thanks. Yeah, so I know that we have a very, very wide variety of experience here in the room today. So let me pull this up here. So what I want to do for the next 20 minutes or so is just kind of bring everyone up to the same page, so that we're using the universal language throughout the day today in order to describe what we're doing and describe how we're going to learn. So first, I'm going to go over just a couple of basic physics principles so that we all know what we're talking about with the ultrasound. We're going to talk about the various colors that we see on the screen with ultrasound, the different sides of the image, the probe motions that we use to obtain those images, and just some basic knowledge, so how we can improve our images and really see what we're trying to see. So the basic physics of ultrasound. Electricity comes into the probe. Piezoelectric crystal inside of the probe converts it into an ultrasound wave, which goes into the tissue and comes back to the probe and is converted back into electrical information, which is then displayed on the screen. Pretty simple. But the question is, what happens to the sound waves when they're in the tissue? Because that's what changes the images that we see on the screen. So the ultrasound waves can be absorbed or attenuated. They can be reflected back when there's a difference in the tissue and that tissue interfaces. They can be refracted between different tissues, and the waves can be scattered as well. So just a brief overview of a sound wave. The sound wave propagates in a direction. We call that wave propagation. And over a certain distance, it's going to attenuate, meaning that the amplitude, the strength of the signal gets smaller, weaker, over a specific distance. So it's very important for what we're doing. So what is the speed of sound? Anyone?
740. Depends on the pressure.
It depends on the altitude, sure, because it depends on the medium. So the speed of sound in a vacuum, sound can't travel in a vacuum. Sound has to travel through a medium. So the speed of sound in air, which is kind of the thing that you first think of, 330 meters per second. I would remember that from basic physics. But then the different tissues, sound travels at a different velocity. So fat is traveling a little slower, bone is traveling pretty fast. We average soft tissues in general, call it 1540 meters per second. But this is important because if you think about wave or laser beam, as you travel through different things, different tissues, your sound wave velocity is going to change. And so that's going to cause refraction when you go between different tissues. So if you're coming down and then the speed of the propagation velocity in the second tissue is faster, your sound wave is going to bend. And then as it comes back, as it's reflected back, it's going to bend again. But the ultrasound machine, it can't tell what the wave did when it was out there. It can only tell when it comes back. So that's going to map it out as having been a straight thing. So that's an important thing to keep in mind. So that's one thing the wave can do. It can do refraction. Attenuation. So like I said, this is the wave getting weaker over time. Notice that water, its attenuation coefficient is 0. In air, it's 12. All the other tissues are kind of in between. So this is a very important concept that different tissues have these different attenuation velocities. So that's going to affect what we see on the screen. And I want to point out, the units down here for attenuation, decibels per centimeter per megahertz. So the amount of attenuation you have changes for the frequency of your probe. And each probe has a specific frequency range that we can use. And so if we have a higher frequency probe, it's going to attenuate faster. So you're not going to be able to see as deep into the tissue because your ultrasound wave is going to get weaker and weaker. We use a higher frequency probe for superficial structures and a lower frequency probe for deeper structures. Higher frequency gives us better resolution. Lower frequency gives us better penetration. So reflection, this is kind of the meat of ultrasound because this is what comes back to the probe and what we see. The sound waves go down at tissue interfaces throughout tissues, it's reflected back to the probe. And if you remember, angle in, angle out, basic trigonometry principle or geometry principle, if you're at 90 degrees to the tissue interface, all of that sound, all of that energy is going to be reflected back. We call that a specular reflector. So it's going to make the image really bright and you're really going to see everything that you're seeing. If you're at a different angle, then some of that is going to be reflected in a different direction and you're not going to see as bright of an image because you're you're going to have a weaker signal coming back from the probe. And the last thing that the sound waves can do when they're in the tissue is scatter. So if you hit a smooth, uniform surface, you're going to have all of that sound wave reflected back. If you hit a non-uniform surface, it's going to be scattered, and the sound waves are going to hit different things, there will be different angles, and they'll be scattered throughout. So how do we take those principles of what the sound can do and explain the colors that we see on the screen? So the first color, anechoic, black images. So this is going to mean that there's no echoes coming back. The sound wave travels straight through and is not reflected back. So remember the attenuation coefficient of water and blood, very low. Fluids are where we see black. But there's also artifacts in ultrasound. This is a very important part, especially in lung ultrasound, where we're trying to see the artifacts. And so the other thing that can be black is artifacts. So here's an example. This is the IVC. We're going down, it's gray, it's gray, it's gray, and then it's black. So this is fluid within the IVC that we're seeing. And it's anechoic. The ultrasound waves are going straight through, not being reflected back until they get to the back wall of the IVC. And here's an example of an artifact. So this is a port, and the ultrasound waves come down, and the port reflects all of the ultrasound waves back. So we have a shadow behind the port. There's really tissue back here, but you're not seeing it because you're seeing a shadow of the ultrasound waves coming in. The next color is a simple gray. Your hypoechoic. So some echoes are coming back, but not all of them. Hypoechoic. And so all the soft tissues, solid organs, they're all going to have various degrees of hypoechogenicity and send back a certain signal. And if you remember again, the attenuation coefficient is different for all of these tissues. They're all going to have a different appearance to them. So this is kind of a really classic view that we're going to come back to a couple times. So this is in the right upper quadrant. We see the liver here, and then we see the right kidney and the psoas muscle. So we have liver, kidney, and psoas muscle. They all have different appearances. They're all soft tissues. They're all hypoechoic in different ways. And then you can also have gray artifacts. So here we can see what we call a reflection artifact. Above the diaphragm, we're seeing a reflection of the liver because the diaphragm is reflecting the ultrasound beam off the diaphragm. It travels and it comes back to the probe. But again, the probe doesn't know where the ultrasound beam traveled. So it's plotting everything that's reflecting and forming a mirror behind the diaphragm. The last color, white, bright, hyper-color. So white things, they're going to reflect back a lot of the echo. All the ultrasound wave reflects back. A couple examples here, bone, periosteum, pericardium, things that are going to provide very strong reflections. And also air is going to appear white. So here's an example with bone. You can see the periosteum of the bone is reflecting back all of the signal. But again, you can have artifacts. All of these colors can also be artifacts. And so we're seeing a white artifact here on the screen. And this is called a reverberation artifact that's occurring because nothing is getting beyond here. It's reflecting back up and coming from this. It's coming down, reflecting. And so it's plotting these artifacts on the other side of it. Here's an example of air. So this is another white line, and these are the rib particles here. And you're seeing just the interface between the tissue and the air because the attenuation coefficient of air is very high and air is a scattering surface. So what we're seeing is really just the interface between the tissue and the air, and then all of this is artifact. So now that we know the different colors and kind of how we get those colors, let's talk about how we're going to actually obtain the images today. So CT scan, everything's at 90 degrees, everything is the same image. You could get scans in other ways. You can get a chest x-ray the other way, but we have these standards that make it so that you can read in the chest x-ray. You can understand that any CT scan you're looking up can be. And so we do the same thing with ultrasound. Even though you can't put the probe on in any way whatsoever, we have a system that makes it so that you can understand the images and the images can communicate themselves. So every probe has a leading edge indicator, a dot or a light or a notch, something on it that indicates which side is the leading edge. And that's going to correlate with your image on the screen with the leading edge indicator. So we call this side of the screen the leading edge, and the receding edge is our other side. Then near the probe is the near field, and far away from the probe is the far field. So if we look at this on an actual image, we have the near field near the probe, the far field away from it, the leading edge, and the receding edge. So for this particular image, the probe is positioned with the leading edge on the patient's right, and that's kind of our standard. The the leading edge to the patient's right or towards the head. So on the leading edge, we have the patient's right. On the receding edge, we have the patient's left. This is a subxiphoid view of the aorta here, so we can see the near field, this is going to be anterior and posterior. So if you think about it, this is the same image you would get, the same orientation if you had a CT scan looking up from the view. The probe motions are difficult to describe. So what we've done is come up with a uniform description that we're going to use throughout the entire day so that you can understand what the proctors are trying to tell you, you can make suggestions to each other. So we're going to go through it as moving in the x-axis, which you'll do large motions in order to find whatever anatomy you're looking for. Then we're going to center an object within the screen in order to move in the y-axis. We're going to talk about changing our axis through the long axis and the short axis. So the first thing is finding an object. So we can do this with a sweep or a fan. And a sweep is a large motion where we're moving the x-axis or the short axis of the probe. And we're maintaining a constant angle of inclination and moving the footprint of the probe. These are great little diagrams to show that. And then a fan is going to be different in that we're keeping the footprint in one place and we're changing the angle of inclination. So how are these show different images? This is a sweep. So we're starting here with the probe in the mid-axillary line and sweeping posteriorly. And you'll notice that the near field and the far field of the image are both changing. And it's, this person sweeps posteriorly, we can then see the kidney here with the liver. So that's going to be a little bit different from what you're going to see with the fan. So here the probe is already in the posterior axillary line, and as the person fans, notice the kidney is changing a lot. In the near field, we're staying pretty much on the same portion of the liver. So this is coming out and fanning back and forth. And so you're seeing the far field change while the near field stays the same. So this is a great way to interrogate a structure like this. The next thing is centering an object. So here we can either rock or slide. So these are both movements in the long axis of the probe. The slide, similar to when we were sweeping, the angle of inclination is going to stay the same, and we're going to move the footprint. As opposed to the rock, the angle of inclination is going to change, and the footprint is going to stay in one position. So here is an example of sliding. The probe is slid superiorly, and notice the entire image changes. So we go from focusing on the kidney, now we're focusing on the diaphragm. The near field change, the far field change, the orientation of the image stays similar. So this is going to be different from a rock, in which, again, the near field is going to stay pretty constant, and the far field is changing. So you can see how the spine here is fanning back and forth. It's a bad choice of word. It's rocking back and forth, sort of like a ship rock. And finally, movements around the z-axis. So if we call the center of the probe the z-axis, the line going right through it, we can increase the pressure moving down along the z-axis, which would produce a contact artifact of the skin. Because again, the ultrasound beams will not travel through air. So if there's any air within the ultrasound probe with the skin, you're not going to be able to see anything behind it. We can also rotate around the center of the probe. And this is going to change our axis through the object. So everything in the body has a long axis view, a short axis view, and 178 views in between. So our objective is to figure out, what is the exact long axis, what is the short axis, and how can we find those. So here's the same view of the kidney and the liver. And notice as it rotates, we're seeing we're still in the same focus, but the image is changing as we rotate. Last thing I just want to go over real quick is some basic knobology, the study of the knobs. The first thing that for every ultrasound machine, like Dr. Blankenship was saying, that surgeon needs to find is the power button. So all machines have a power button. They also have a power cord you plug into the wall to do power. So it's important to identify that. It usually has like a power symbol on it, the word power. And then there's a patient button in a different place on every machine. But this is where you enter patient information so you can save your images and things such as that. The next things, the next two, are really the main things we're going to adjust today, the depth and the gain. These are kind of the ways that you can start making your image better. So as for depth, which you can see sometimes is a button, sometimes it's a knob. Changing the depth so that you're really focused on what you're trying to find is important. So on any ultrasound image, you can have too much depth, and in the far field, you're just wasting space on the screen. If you have the image that you want focused, and you're using the appropriate depth, then most of the screen is being used confused by the interesting data. The other thing is gain, which again is on some machines with buttons, on some machines with knobs, and this is going to change kind of the whole brightness of the field. Everything on the screen is going to get brighter with more gain, and darker with less gain. It's kind of like the volume of the sound. Also on some machines, there are sliders that can adjust the gain in various levels of the screen. These are a little bit more advanced things. There's a focal zone, which can be adjusted. We'll talk about that in a second. And then there's also specific modes. So there's all sorts of presets in these fancy machines that make it so that your images are better. And using the appropriate mode, such as cardiac mode or abdominal mode or OB mode, make it so that the presets on the machine are focused on what you're trying to look at. They also make it so that you can use different calculations and just make the whole experience much more exciting. And then you can label your images as well, so that the whole image speaks for itself. So like I said, focal zones, so the ultrasound beam is not really a single slice. It's got a little bit of a third dimension to it. And the focal zone is where the focus of that energy is going to be. So you want your anatomy of interest to be right at the focal zone or just superficial to it. And a couple more advanced things, you can use tissue harmonics, which reduce some of those artifacts, as well as dynamic range multibeam. These are a little bit more advanced than what we're hoping to cover today. So does anyone have any questions about the basics of ultrasound, the various colors, the probe motions? Okay, thank you.
So we're going to move over to the CSAC, but real quick, what are the three colors of ultrasound? What's black ultrasound? They're fluid or artifact. What's gray on ultrasound? Tissue or artifact. You can see a pattern. What's white on ultrasound? Air is white on ultrasound. What color is air on CT and X-ray? Black. And so air is going to be white, bone is going to be white, dead structure is going to be white. Four sides, what's the top of the screen called? Near field, bottom, far field. Vending machines, the dot's going to be on the left side, and that dot or that indicator will be what? On the right side. Leading edge, LL, left leading. On the right side will not be a dot, that's the receiving edge. And then if we have a probe, but we're going to move it, if we're in the long axis, what is that called, that motion? Slide. We're going to lead that from the receiving edge, and that is the long axis. You move it with L, that's the slide. Keep the angle of incidence 90. If I change the angle of incidence, what's that? Rock. If I have a problem with centering, I either rock or slide to solve it. If something's not centered, what's centered? If I move in this direction at 90 degrees, what do we call that? Sweep. Change the angle of incidence, fan, and we're going to rotate. Just so we can communicate when we're going to do that. Why don't a couple of Ohio States, what we're going to do is we're going to, I think we have to walk outside and go over to CSAC right across the street, and we'll go up to the 6th floor. It opens, I think the doors open. You can take some people down through the back way, but I think that most of us, you guys want to get your coats, and we're going to go over there for 2 rounds and come back here for lunch. Back to the
tendons, you know, any fluid shows up beautifully. Nerve blast, things of that nature. Yep.
You use like that in a more obese patient, or like what's the difference in like the actual size of the head? What would make you choose one over the other?
Yeah, absolutely. Hop right on, and actually while we're talking, because I want you guys to get. So these beds are not the best.
Later, you're teaching him cardiac.
Shuffle it.
I'm a second year resident. You guys are from? Oh, you guys
Yeah, I think that'll be okay. I think this is one of the older. Don't worry. So,
we can go over it. How you guys have?
At least I don't think I am.
Okay.
Brennan James. Nice to meet you. First year. Let's get
When you change probes, your screen is showing opposite for the presentation. Can you change the probes? Does that change also?
Yes, it does. So we can show that. I want somebody who has not touched a probe to start touching and playing and spinning around right now while I do some boring lectures. Okay.
It's okay.
What's your name? I'm sorry.
Brennan.
Brendan and Denise. Right?
So so there's this knob on the side. Feel that? That's corresponding to the Sagittarius. So notice if you touch right here on the probe, right? You can always check inside your leading edges. Yep, you got it. So you can always check it. So go ahead. What I'd like you to do is I would like you to do the first images in the fast scan, which is the hepatorenal view. So go ahead and just stick it on. Sure, stick it with the leading edge. Sorry, I'll get some from the lecture points. The leading edge towards the patient's like that. Perfect. And so get comfortable where you can see. Get comfortable in a position where you can see the screen, as well as be able to.
Go for it.
You just push that red button on the bottom by the wheel.
Press harder.
You need to push. It is. It's a red.
Because you want the surface to be flat again.
Slide around. So.
It's called longitude.
Cool. So, by all means, play around and scan while I'm talking. I want to make sure that people are getting time to scan in addition to not just listening to me talk. So you start to get a feel, feel for the probe, feel for the anatomy. And Denise can also help us as we're talking.
Gotcha. Okay. So once I post it, can you
So as you start to, as you
Yes, I'm smart here, yeah. Very nice to meet you.
Thanks for having me.
Yes, I mean, on the right side is. Here's the AC joint. It's not a perfect image because I'm a little bit off of 90 degrees. So you're not seeing this perfect surface with the white surface. But it's part of the AC joint is a little bit of a V between
So this is a big thing is air, when the ultrasound hits air, it doesn't go through it at all. So you don't actually really ever see lung tissue unless there's something wrong with the tissue. So in our healthy patient, we shouldn't see it. When we kind of a starry night sky, it's kind of the appearance they typically describe as the liver. So then, you know what this is? This little white thing kind of flipping up like this. Yeah, so this is a diaphragm coming into the ulcer. So you're actually a little bit higher, all the way pushing. So, and then we kind of see some kind of like light, see something behind it. This is where you're getting your So I'm going to reposition it a little bit. What we want to find is the
Hanging around and
Okay. Normally you want to put it like tight and go all the way and a cold structure support.
I don't know. So you want to visualize everything you visualize. If you start at the top of the kidney, sweep down the right. You can see that there's no fluid the whole way through. Like I said, in this scan, right kidney, liver, muscles, pouch, diaphragm here. Take a deep breath. Down. That's called a current sign. So you already tried one. Do you want to do one view each and then rotate, or do you want to do all 4 views? All 4? All right. So you stay on the side of the patient for all 4 views. It's a little. This is a challenging view, especially because you have to reach over.
Which is also
Where's your leading edge? I think it's down. Yep, it was. Yeah, so you had a patient facing down, so the image is back. So this is the leading edge. Here, you can see it kind of moving the top. So you want that turning towards your head, so the image is upside down. You did a good job, you just had it.
Very good.
Is this the left kidney?
I think it might be.
Proctors, fluid is not in between the bleeding. Kidneys are one thing. You go above the kidney,
If you're not sure, you can always try longitudinal.
So what you're going to do is start sweeping towards the right. Yep. Just make sure you follow down the right.
What do I do?
Came up on the right.
Okay.
So this one.
You have the right idea. So
Okay.
just follow her rib as an organ. Just go this way. See? So look at the structure of this thing. So that's literally
I like watched us. The thing is, all right.
Or if you're not
So,
There's also second connection there as well. So abdominal.
so I can use images. What do we think?
So you typically do gallblass.
So what is that? So this is the left ventricle, it's pretty big. That's what would be the next best.
And keep mixing the universe.
And
Go in slowly. Flex means you may not actually get the same thing you can. So, zoom the thing back out a little bit and try to run it in that case.
You have to get the angle just right, and you'll see the light. I mean, you'll see the iris, you'll see the pupil, and you can shine the light. You'll see.
Yeah, makes longer and your eyes closed.
Our fourth year webmaster tweaking.
A little bit. We have an account. I'm part of that, but I haven't been keeping up with it. I have a committee that I've been trying to get to do more things. So it's a little difficult.
I have a committee, it's called the.
Not a ton.
Just remember to do it.
So it still looks left and right.
Yeah, I mean, but you know you're oriented.
Because of my orientation.
Yeah, you're
I do not
oriented.
know my orientation.
Yeah.
Okay. Up and down. Okay, that makes
Always,
sense.
just always,
That makes
when you
sense.
just gotta always know when you're looking at the leading edge, and also there should be. I'm gonna reach over you. Pixel of the eye.
I guess it doesn't have pictures of the eye. But you can type it in if you need to, just so when you save the image, you know what you're looking at, and also you can put leading edge towards head or whatever you need to orient yourself. Usually there are pictures, but this one doesn't have them.
And then the optic nerve is 4.3, the standard depth.
It's usually a little bit more shallow than that, but I just want to make sure we have everything in the image so we can kind of see it.
In the optic nerve, would you wear?
In the far field, you kind of see you guys are trying to turn it looks like a monkey. I don't know how to put your
We went there. What's that? That won't hold it against you.
Sometimes you can see them.
How do you know if you're seeing blood or like how many different? You have
But if you don't, you're seeing blood work. So that you're seeing. So that's one of the, that's the same limit on, that's the same limit on everything now.
Okay.
You're just gonna see something.
You measure it.
Anything else you want to look at? See, I see that.
I'm not sure what they're covering on MSK, but
It's kind of hard. It's abdominal. It's like looking at what's your beside with the growth that we have.
Interesting connective tissue things.
Let's see.
Just what each
What
kind
of
Older men, and what really would be a big evidence for that? He was an older man who also smokes, right? So potentially smoking of this old man equals why they actually offer the screening test.
Oftentimes inmates come in with like, oh, there's something in my eye. Either after a workshop or whatever else. Somebody hit me with something.
Usually,
You know, it feels like something in my eye.
The sensitivity of facts is kind of debatable. People talk about it being more sensitive in the original papers than kind of subsequent studies have shown. But if you do a repeat PET scan, then there's actually, it increases the sensitivity quite a bit. They were doing them about 4 hours on average from the first one, so this is something that they're doing more as like an patient. But any patient that becomes unstable or change in their acuity and change in vital signs pretty fast, I can tell you a lot of information. This is may not have been a lot of the last time he came first time. That's why you get a wide range of reporting. How much blood because for the surgical interns that we're doing one of these studies, almost like subdiagnosis. You're going to be holding it. So theoretically, all of their positive aspects are probably in. That's not truly your first time shot.
3 is small aneurysm and then above 5.
That's just kind of weird.
So that's what you want to address as far as these measurements. So
but if you do any website is public, if you go to OSU Ultrasound.com.
Really bad?
So I've heard they're preparing
What's a normal part to do is you can't get past.
Yeah, sounds like a really good idea. That tells you so much right there, right? Because you got the diaphragm, you got the liver, you got the Boysen's pouch, everything right there. So, and that's when I'll switch my hand to the top of the throat. That way I can shoot down into the chest and make sure to increase your depth.
Oh my goodness.
I've had this done here. I know that. So
I'm used to it. Yeah. Yeah.
Show me IBC.
So make sure your bedside is correct.
Didn't know this.
You had-
I'm talking about
Yeah.
the expert. That's good. Yeah, that's perfect.
I feel like
It's all set.
so hard. It's hard to keep my eyes. Well, I'm not doing it,
All right.
Your rescue, that would be, doing that, you just have some people in the belly or what you call like these big traumas shut you down on their belly. You can put the probe on the
Yeah, so like if we're in the legs, that's kind of like this back. You just use a screen and like shake it through it and see color like top of the screen. And you shade the best.
Look at problem. Can be nerve. That's what you can do it for. All right, look at the nerve. Let me sit up.
So the heart, this looks like, that's the one that you want to know. Otherwise, you go like pencil. Yeah. You want to put it down, maybe.
So this, you need to do median nerve block. Give it to the patient. Put the gel in.
One thing that I
So you want to put on the right
what yeah, so you can see if you were trying to get a view like in the right upper quadrant.
Yeah,
so
I guess what it also looks like there.
You'll get your view like this. Plain kidney diaphragm.
So what is it?
But I was just talking there, so look where your it will kind of layer out, but it can be up there.
I don't know.
Here's a picture I was talking about. Yeah, the cynicals. See how those seem vesicles. You can imagine if they were a little bit large on this guy, you might call that free fluid in his bladder. What a real positive basket. You see how those kind of just, it's almost like a sharper angle, whereas the seminal vesicles, see how they kind of
So big thing, a lot of schools are trying to
anything blunt and sharp corners, that's when you can get tipped off. It's actually
not necessarily just
exactly.
It's like looking for blood brain.
Yeah, exactly.
So they're trying to bring patient safety.
I am, as always.
I tell you, man.
I'm like living the life for a dream. I'm like, I'm going to workshops now.
See what it's all about. There we go. So, let's say you had someone that had a big distended belly, had abdominal trauma, and you do a fast scan. They're tachycardic, and they got you do a fast scan, it's negative. Why might that be?
When you're doing side
Another good way, I'll give you more. Let's say they had a hemoglobin, yes, like right before they got in the car, left the hospital, had a hemoglobin, it was like 14, and now their hemoglobin is right after that. Yes. So ultrasound can't find even when you know they have regular I put some probe on it. Surely there's got to be a way.
Otherwise,
It is awkward. It's one of those things you like. So I never.
There's a kid that is a year ahead of me, so he's so I didn't know if that was like rare.
Yeah, there's like there are 16 spots. You've got your diaphragm, you've got like more counts. They're asking
Yeah, yeah.
That's another thing, my big challenge is if you train ourselves to know is so what I should do is everything we're looking for on ultrasound fluid that you just don't have the only time but then I would get into like a little bit higher stuff here, but like a lot of times will help you more than if you're trying to get a better looking picture. So I would say you're trying to get a better looking picture, decrease the gain and try and do the other tertiary.
Okay, you know, like from my growth in that
theoretically
good. Go back.
What did you press?
So the most anterior is going to be the RV.
Yeah, so that's basically your only right now.